So hello, everybody. Thanks for joining us today. During the last lecture, Matt covered an overview of testing, including a brief review of the reference method, bias, and imprecision and allowable error. And he also introduced the importance of the laboratory having mechanisms in place to ensure we have valid, reliable results. And this is where we're going to pick up from today. So we're going to spend about the next 40 minutes thinking about quality control. Specifically, we're going to look at ways the lab identifies whether assays are working as expected using internal quality control and external quality assurance. So what are the intended learning outcomes from today? So the first half, I hope you'll be able to define the components of internal quality control, explain why we perform these measurements, and understand what materials which should be used for IQC, and perhaps some of the limitations. And then in the next part of the talk, we're going to define EQA, and including some of the schemes that we use here in the UK, understand the process of interpreting these reports, and then hopefully overall from the lecture, I want you to gain an overall understanding of how QC data is analysed and actioned upon. So we want to make sure for every test a patient has, so blood tests are the commonest, but not just blood tests, the results are both precise, so the same every time, and accurate, close to the target. And there are lots of parts along the patient pathway, which Matt talked about last week, where this can go wrong from even before a patient enters the room. And quality control can help detect errors or problems, all with the aim to make sure we get the right result for our patients. And in the most part, IQC and EQA can help detect analytical errors, but also they can identify some post-analytical and some pre-analytical testing errors too. And you'll learn later in this lecture series about specific errors that may impact different types of analytical methods. So there are two key components that we're going to look at today. And it's first of all important to say that these are only part of a lab's overall quality management strategy. The first we're going to look at is IQC, and this is part of your daily routine in the lab. It would occur at regular time intervals during the day. For example, if you're doing a continuous assay, such as sodium in a busy auto lab, or at specific time points in a batch assay. So, for example, at the beginning, middle, and end of such an assay, where you're doing it less frequently, like something like renin and aldosterone. EQA is usually every 2 weeks, but sometimes it's less frequently, and the lab gets sent samples from an external agency to process and treat as they would a routine patient sample, and then the external agency compares your lab result to your previous performance and to other labs and to other methods for that same analyte. So that's the overview of the two key components we're going to look at today. So let's go into a bit more detail about IQC. And in brief, IQC material contains analytes of known concentration that we test routinely during an assay. We know what concentration result to expect, or the range the result should be within. And if the result we get is outside of this range, then we need to consider whether or not we should be releasing the patient results we have that have been tested alongside this IQC. So why do we need it? Why do we use it? We need it to produce reliable patient results that are analytically precise and accurate. And the patient results in most instances should only be released if the IQC falls within the requisite range. So what actually is IQC material? Well, this is a picture of some that we use in our laboratory. And it's often liquid that's ready to use or freeze-dried material. And it's supposed to resemble human serum, plasma, blood, urine, CSF. And Matt mentioned the effect a matrix can have on an assay the last time. And this perhaps is a clear limitation of some QC material, that it's not always exactly the same as human fluids. But there's, of course, whilst you want it to be similar to the sample you're testing, you want it also to be stable for prolonged periods without any other preservatives in it, and you want it easy to store and dispense. You also don't want to expose the laboratory staff to any communicable diseases, bacteria, viruses, fungi. And also, you want your QC material to be at the right level for the assay. And what do I mean by that? Well, if we look at sodium, for example, we want to include levels that cover the range so we know we're detecting not only normal sodiums, but also hypo and hypernatremia as well. So probably most labs will have at least 3 levels of IQC, normally around 120, 140, and 160 millimoles per litre, for example. However, if you think about another type of assay, for example, troponin, you might choose a different level of internal quality control. Because what's important here is that around the cutoffs that we use for ACF, we want the assay to be accurate and precise. And so we need to perhaps include QCs rather than being evenly spaced like we might across a sodium assay to be around that medical decision limit. And what levels of IQC do you need? Well, you want normal levels, but you also want abnormal levels. And if you're doing a qualitative assay, you want a positive and a negative control as well. So what have we learned so far? Well, the QC material you want to have, you want it to be similar to the sample you're testing. It needs to be stable, easy to store and dispense, and free from diseases at an appropriate level and affordable. The next part that we need to think about when we have a QC is when should we be running it? And this is kind of a difficult question to answer in a single slide or in a few minutes. The first thing to say is that all quantitative assays should have an IQC in every run, and a minimum of 2 levels of IQC should be run once on the day of performing the test. But the best practice, it takes into account the frequency of the number of samples that should be processed, the reagent stability, the impact of an incorrect patient result, and also the local experience and the schedule of the laboratory, how your equipment runs. So actually each lab's IQC timetable may be slightly different. And then also, if it's a batch assay, you're not going to be running it continuously, but you may run it, for example, at the beginning and the middle and end of the assay. The second thing to say is not only do we run it kind of routinely, but we also might do what we call event-driven QCs. So, for example, if something big happens to your assay, to your equipment or your assay, then you may need to rerun the QCs. So the instrument's being serviced, you've changed the reagent lots, you've calibrated, or you're getting a lot of delta checks which seem unusual or different, and then you may rerun the IQCs at that point. So we've looked at the first few learning outcomes, and now we're going to think about how do we interpret or use this IQC data in the laboratory. So we've got our QC material, and the first thing for an established assay that you have in the laboratory, and what would you do with it? How would you go about employing that in your lab to help determine whether an assay is running okay? So the first thing you would do, ideally, is run this over 20 separate batches and get the mean and SD of the results from those batches. And the measurements subsequently on these control materials are then compared with the the distribution beforehand, and they're plotted on this chart, which you can see a graph from our lab, which is called one of the most important charts in the laboratory, which is a Levy-Jennings graph. And what this actually is a graphical method for displaying control values and evaluating whether a procedure is in control or out of control. And on this control chart, daily or more frequently than daily control values are plotted versus time. And what it does is help us identify in a graphical way both systematic and random errors. So you can see from this graph that they're all nicely within this, mostly within this kind of nice blue area. But actually, how do we assess and check that our sort of assay is in control, as we say, and how do we go about using our IQC results? It's beyond the scope of the talk to go into detail about this, but I want to show you some key examples. So the first thing I want to do is remind you of the relationship Matt went over last week between SD and normal distribution. So in a normal distribution, about 68.3% of the distribution falls within 1 SD of the mean, about 99.5% within 2 SDs of the mean, and about 99.7% within 3 SDs of the mean. And we use this to determine the rules by which we may accept or reject QC values. And one of the most important people in this area is someone called Westgard, and he has developed rules that can help us determine whether our QC is in and out. So, for example, if you look on his website, which is referenced at the bottom here, you will see all these different types of rules. And when it says 1,3S, what that means is that once you had a QC value that was above 3 SDs, either above or below the mean. And normally, this is called what we call a rule violation, and we probably would reject that QC and say that it's out because we know that this should only be happening 0.3% of the time. So normally, that shouldn't be happening. Whereas if we look at this second rule, again, 1,2S means one value which is outside 2 SDs of the mean. If we use that rule alone, we're at risk of falsely rejecting approximately 4.5% of the runs with 1 QC, 9% of runs with 2 QCs, and 13% of runs with 3 QCs. So you can see that determining which rules you employ is important, because you don't want to reject runs that are actually okay, but you do want to be able to reject runs where the QC is telling you that the assay is not in control. And so there's not just those single rules, there's also multi-rule QC procedure, perhaps beyond the scope of this lecture, but something you can look at afterwards, where you would go along a control process, not just looking at a single rule, but multiple rules in a row. So let's just imagine that our QCs are out. What do you do? So the first thing is you have a look at your patient results. You would repeat samples that have been done after the QC is out. Check things, simple, straightforward things. Are my reagents in date? Does the machine need calibrating? Is the QC okay? Have I been left out? And that's the problem. Check things like the temperature, the technique, and the instruments. So let's think about a bit more about the Westgard rules and how you might identify different errors. So the two main errors that we might identify with IQC are systematic and random errors. And systematic errors tend to be problems with calibration or blanking, and they can happen with reagent lot changes. And so these are the type of rules that you may see when there's a systematic error. So you may see, and typically here you can see that the rule violations are all on the same side of the mean. So here, for example, you've got 2 2SC rules in succession. Here, for example, you've got 4 1SDs in succession. All of these are symptomatic of a systematic error. The other type of error that QC can identify is random error. And this is particularly maybe the QC material is again left out on the side, hopefully never happens. There's a new operator who doesn't quite know the procedure, has made an error, the system itself is failing. And if that is the case, then it typically is not just one analyte that's affected. So that may help you identify, or there's a lot-to-lot variation in reagents. And this one, you can see where the rule violation is over 4 SDs between the two QCs here. So then what do? You found your error, you've remedied the error, you need to repeat the batch, you need to report it on your lab system, and you need to log it, and maybe you might need to amend results, and you need to then contact the clinicians that are affected by this problem if you've released results whilst the QC was out. That's kind of on a day-to-day basis, but on top of that, you should be doing a longer-term review of the trends. And this is, for example, is a published paper you can have a look at, which shows that when they were looking at the median of serum creatinine results, and you can see that for most of the month, the medians were very, very similar, but suddenly they jumped up. And if that happened in your results for your QCs, then that would help. You need to then do some looking into why that's happened. And the reason that it happened for them was there was a change in reagent lots that weren't verified, and that's why things had changed. But if you haven't done that longer term review, you may not identify that error. So not only might you want to do the daily routine, but also a longer term review of IQC trends. And this was just a worked example to say, when do I need to stop running my assay? Well, it's fine here, it's within 1 SD. My computer has stopped working. Sorry, yeah, and apologies, it's stopped working there, but here we've got over 2 SDs out, and therefore we would stop our assay at that point. So the final point I want to make about IQC is that there are limitations. It may not detect all of your issues. The problem with matrix effects we mentioned at the beginning, because the IQC material has all these conflicting demands and it may not be exactly similar to the matrix that you're testing. You might not detect random error. And often detection occurs after, for example, in a continuous assay, after patient samples have been affected. So if you're running sodium in a busy auto lab, then sometimes you may have released results before you realize that the QC's out. So a really useful paper, I think, to go and read now is this best practice paper, which was written actually a little while ago, but this is a really helpful paper to just review some of the things we've talked about today, and I would really recommend it. Okay, so now we've talked about IQC, I want to move on to the other part of the talk, which is EQA, and this includes, not only does it include what we talked about with the sort of external agency, but it also includes things like interlab comparisons. So you may not have an external agency that tests your particular analyte, but you may decide that you want to set up a sort of interlab comparison with people running the assay anyway. So what does actually EQA involve? Practically, what it involves is receiving a set of samples through the post from an external organization and incorporating those into your routine lab workflow. And the labs don't know the concentration of the components in the samples, and they perform measurements in the same way as they would for patient samples. The results are then returned to the EQA organizer for evaluation, and after some time, the lab receives a report stating the deviation of their result relative to a true value, which is assigned to the sample. And the report may also include an evaluation of whether the individual lab's results have met the analytical performance, so the minimum performance specification for that assay. Frequency, well, monthly to bi-monthly is the commonest frequency. Normally it's every 2 weeks, but the key point here is that it's retrospective. And the comparison of a given lab's performance on a certain day won't be notified to the lab until sometime later, so it won't influence results from the day of the test. So what do I want to know from my EQA? Well, I want to know, are my results close to my target? Is my assay consistent? So is it consistently out of target? How do I compare with the other labs, the pink lab and the blue lab? And are my results getting better, worse, or are they staying the same? And you can also find out other things from EQA. You can find out how different methods compare. Is precision affected by concentration? And also you can find out what other assays and methods are used by other labs. So these are examples of the schemes we use in some of the schemes we use in the UK at the moment. And this is not all of the schemes, and this is not all of the data that you may get. The commonest one you've probably heard of is NEQAS, because this is a huge scheme. And then I've put here some of the key points, which is what's the target that you compare, the scheme compares your result to? What sort of data do they give you, and any other comments that I have. And the reason to put this is because, for example, NEQAS often uses a kind of a mean or a trimmed mean to compare your target to give you your target value, whereas WEQAS, for example, may use a reference method to get your target value. So you need to understand all these bits about your scheme to be able to get the best use out of them. And then the other key point about this is that there's these things called National Quality Assurance Advisory Panels, and they have responsibility for monitoring EQA schemes in each of the disciplines of pathology, and through them, the performance of UK laboratories participating in those schemes. So, for example, if you're having consistently poor performance, then there are other agencies that may get involved because of that through the EQA scheme. So let's just spend the next few minutes talking about how might I interpret my EQA report. And I'm going to focus on NEQAS just because that's one of the biggest schemes in the UK. But all of the schemes have a similar way of looking at the results. It just may be that they have slightly different names or slightly different calculations. So in NEQAS, if you've got your single individual result, what do you get? You get your result. So you can check you haven't made a terrible transcription error. So you think you did a sodium of 142 and you wrote it in, but actually turns out that someone typed in 122, then you know there's been a transcription error. So they tell you what your result was. They then give you the percentage bias, and they calculate this by your result minus what they say the target is, divided by the target times 100. And here I'm just reiterating what we talked about briefly before, which is the target. How does the scheme choose the target? It may be the all lab mean, the ALM. It may be the all lab trim mean, so that they've excluded outliers. It may be a method lab trim mean. So, for example, if different methods for the same analyte give very different results, the scheme may decide to only give you, to compare your result against only people using the same method. And then, for example, you have a result of 180, the target that they want is 200, therefore your bias in this example would be 10%. So for a single result, you also get from NEQAS something called the specimen transformed bias. And this is just the percentage bias we just worked out there, which was 10%. And then they've transformed it by this degree of difficulty factor. And it's difficult to find much about how this degree of difficulty factor is worked out. But basically, it's assigned by NEQAS depending on the degree of difficulty of obtaining the target value. And then finally, they give you this specimen accuracy index, which is just the modulus of the specimen transformed bias. So it's always a positive value. And this is an example from the RCPath website that you can look from a previous old question. And it's just helpful to look at an actual report, and you'll get what your analyte was that you tested, what the methods were, and your method here was Beckman reagents. Again, it tells you what the type of specimen that you were testing was. So here, human serum. And then it gives you what your result you gave, what the target value was, and that's based on the method mean. So they have only given you the method mean as opposed to the all method mean. And then they give you your bias, which we talked about how that was calculated, and the transformed bias, which was your bias times by this degree of difficulty factor. And then they've got the accuracy index, which is the modulus of that. So that gives you all of those values. So that's for an individual result. And then you get these things called the A, B, and C score. And what is different is that those are results calculated over a rolling time window. So those are results normally over at least 6 months to give you an idea of what your results are normally like, or what the accuracy and bias of your results are normally. And we'll just go into a bit more detail about what this A, B, and C score are. Just my screen has frozen, so just give me a second. Okay, yes, so just to reiterate, A, B, and C scores look at the performance over time. So they're not looking at a single result. And the A score, or the accuracy score, like the specimen accuracy index, is transformed to make it broadly comparable across different analytes. The B score is how far away you are by a percent on average from the target. So it's the average of the specimen percent biases in the time window. But the important point is the bias, the B score is not transformed. So the acceptability of the B score will depend on the analyte that you're testing, but the closer to 0, the better. And then the C score is the SD of percent biases within the time window. And it's also not transformed. So the consistency of the C score tells you on average if you have the same bias pattern. And again, the lower the better. So let's just see how you might calculate that. If you had the following specimen accuracy index, we talked about that's an individual result, then your A score would be 97. So just the mean of those scores over time. And that just shows you here that, for example, for your individual result, you had this accuracy index of 244, but your A score is very different from that, because normally your A score or your accuracy, not exactly the same as accuracy, but your accuracy is much better than you got for this particular result. So you would look in and see what is happening to the lab and what happened for that particular assay. And then to think about, why do we need these B and C scores? Well, you can see, hopefully, here's the percentage bias, and these are the different distributions. And you can see that your bias is actually rocketing all over the place, but on average, your B score might be 0% compared to this assay, which again has a 0% B score, but is obviously very, very different, or performing very differently. And so for that reason, you get this C score, or consistency of bias. So for that assay that we just looked at, your C score would be very high, whereas this, your C score would be very low. So I hope that makes sense in terms of the NEQAS reports. And then the final thing to say about this is that scores are not transformed. The B and C scores are not transformed, so they need to be interpreted according to the analyte. For example, they give these cutoffs for different assays. So for example, for a sodium assay, your B score can be very much lower. Your B and C score actually both should be much lower compared to an ALT assay. And you can understand that from a clinical perspective. And these are the different patterns that you may see. So if everything's small, then you're happy. If the accuracy and bias are large, but actually you're consistent, then you may have a proportional bias. If your accuracy and consistency are large, but you've got a small bias, you've got variability within your assay. Whereas if everything is large, that's bad, and your bias and you've got bias and variability. So that's how NEQAS sort of generally suggests you interpret the reports. But NEQAS is not the only scheme provider. There are other providers, and I don't have time today to go into the kind of depth that we've looked at NEQAS with the other schemes, but just briefly to show you one of the other common schemes, which is WEQAS. And they look at the similar sort of things, but in a slightly different way. So they use something called the SDI, which is an index of total error, and it includes components of both inaccuracy and imprecision. And it tells you very nicely and very obviously here that if it's less than 1, we're happy. If it's 1 to 2, it's acceptable. And if it's greater than 2, it's unacceptable. And they calculate this SDI by doing the lab result minus the target value. And just to remind you that sometimes with the WEQAS, they try and use the reference method to give you the target or true value. And then they divide that result by the WEQAS SD. So it may be known in some schemes as a Z score. And then the other kind of things they do in the WEQAS is they give you an imprecision score. So again, they make it very clear to you what your score is, and also how you interpret that score. And then they also look at inaccuracy as well. And they so that's just an example of different types of schemes and how they may be how they may present their data differently. But you get an unacceptable EQA result, and what are your next steps? So this is a useful reference to look at after the lecture if you have time. And the most things we think about, well, my EQA is there's a problem. Is it a problem with the test performance itself? So is there a problem with the equipment? Was there a problem with the reagents? Was there a problem with the test performance on the whole? What about the internal QC samples? Were they okay? And that may have affected how our assay was running. So that's the first thing that people think about. But actually, in reality, there are huge other parts of EQA that you need to review. So you need to think about, one, was there a problem from a participant perspective? Did we make a transcription error? Did we record the result from the instrument wrong? Did we report it to our EQA provider wrong? Did we mix up the test results when we put them in? So was it a transcription error? Was there a problem from the EQA providers? Did they send us the wrong error? Did they label it wrongly? There was a problem with the sample stability? So the sample wasn't very stable when they posted it to us. So there is other areas that we could consider. How did we handle the sample when it came? Was it just sort of left on the side and not noticed, and then not dealt with correctly and promptly? Was it reconstituted properly? So that's another area you can look at. And then how did we how did the EQA provider handle the data? And this is something we talked about. So error in establishing the assigned value. Are we happy with the target value that the EQA provider has used? Should they have used a different value as the target? And then how did we interpret the results? So that was what I was going to talk to you today about in terms of the lecture. So hopefully in just under 40 minutes, we've been able to define the components of IQC, understand why we perform it, understand what the materials that we can use are and the limitations, and then what is EQA and some of the ways that we can interpret the report, and then gain an overall understanding of how these two important processes are used within our laboratory to make sure that our assays are running accurately and precisely.